Doug Dormer here with lesson 2, week 2, or module 2. And in this lesson, we'll talk about legislation and regulation between the years 2000 and 2016. This is a rendering I drew back in 2016. I initially did this as a part of the lecture. I drew it on a board and thought the process of drawing it would convey the information. It turns out that it worked out quite well there, so I'm just going to put a picture of it and use it to discuss the period from about 2000 to 2016. And so when we begin, we look at 2004 along our little roadmap, when President Bush formed the Office of the National Coordinator for Health Information Technology, the ONC. Now, I find that to be a really insightful decision he made. Rather than focusing on a lot of legislation or mandates or incentives or technologies, he said, let's start by putting together the leadership infrastructure. And he did that with the ONC. Now, at the time, he said that his vision, President Bush's vision for the United States, was that within 10 years, so by 2014, everyone in the United States would have a health record, an electronic health record. Now, we didn't stipulate whether that would be controlled by an institution, the government, or a personal health record controlled by the individual, but rather a global statement that we must begin now, and it shouldn't take us more than 10 years, sort of. And he did express it on 1 or 2 occasions, his version of man on the moon, what was done in the 1960s, when it was declared that we will have a man on the moon by the end of the 1960s, the United States. And so that's the vision that he had back in 2004. And as you'll see, the Office of the National Coordinator continues to play a critical role in the development of health information technology broadly, and certainly consumer health informatics. That was followed in 2008 by something with a whole bunch of letters that we can call the Mental Health Parity and Equity Act. So that focused on the insurers and said, you have to treat people with mental illness the same way you treat people with physical illness. Before that, many insurers excluded the treatment of mental health services from their insurance policies. Now, the story of each of these acts, each of these government acts, bills that were passed that you see and that we'll discuss on this slide, the key thing is that they all made some progress, maybe incremental progress, but none of them made the sweeping progress, the major step forward, with the possible exception of high tech, that or macro. So they had significant, but did not accomplish by themselves what we hoped they would accomplish. So that act began to elevate mental health along with physical health. 2009, we had high tech. I hope you've seen and studied high tech in your other health information classes as part of your degree studies. High tech is perhaps along with macro. Those would be the 2 most important acts, I believe, of this entire period, this 16 or so year period. High tech began to set the requirements and say what the intent was with respect to health information technology first, and second, and particularly health information exchange, and to a much less clear or forceful intent, consumer health informatics. So the ideas of consumer health informatics were there, but at that point, they were not the focal point. Now, later, I had occasion to speak with some of the regulatory people who published high tech and made the requirements and were teaching requirements. And I asked them, this is really pretty simple stuff you're asking, and you'll see what we mean by that as we go today. Why didn't you go further? Why didn't you right out of the blocks go further with specifically consumer health informatics? And he said, we went as far as we could. as far as the industry would let us. We knew that if we went any further, the industry would just revolt. And so we see that as the pattern of why we have incremental progress through till today. And we'll be considering that question as we look at the next part of this lecture after we finish that in the next lesson, after we finish this look at 2000 to 2016. After high tech, which set this technology direction, we had the Affordable Care Act, which also known as Obamacare, which really extended coverage through expansion of Medicaid and a bunch of other things. I don't mean to minimize the range of what was covered in the Affordable Care Act, but it really expanded the coverage to by about 40 million people that now had some kind of insurance coverage that didn't have it before. That meant that they had access to health care. And that meant we had a domino series of effects on what kinds of diseases were being seen, what kinds of treatments and therapies. It was a huge deal. In 2014, we had the Excellence in Mental Health Act, EMH, which was the next step following on 2008's Mental Health Parity and Equity Act. In the case of the Excellence in Mental Health Act, its intent was to say we must treat people, let me restate that, if the MHPAEA was intended to say insurers will pay for treatment for mental health, the Excellence in Mental Health Act said, and now you have to deliver therapies and treatments that are on par with what you would treat physical health. That's kind of a slight oversimplification of it, but it gives you an idea of the direction. And finally, in 2015, we had MACRA, the Medicare and CHIP Reauthorization Act. Medicare is, of course, the payment system for elderly people. CHIP is a special program for children. And following it also, we had some kind of indirect effects on the state payment funding programs for low-income folks, which was called Medicaid. The important point is that MACRA affected the payment models for providers for about a third, and it might be more, I forget the exact number, but you get the idea. The point here is for a huge percentage of the population, and therefore for a huge percentage of the services provided by our providers. And given that these were targeted on elderly people or children or those with lower incomes, they were a fairly high cost, high intervention population. And so MACRA did a couple of things. It tried to get us as an industry away from a model where providers were paid based purely on the services or the products they delivered. Quite frankly, before MACRA, the most profitable way to run your practice was to keep your patients stable but not cured, so that they needed to constantly be involved with you or on an ongoing basis. That's how you made money. One chief financial officer told me once, "What business do you think I'm in?" I foolishly said, "Well, I think you're in the healthcare business, taking care of people." And he said, "No, I'm in the real estate business. I rent beds. Everything I need to think about from a business perspective has to be keeping my real estate, my rental properties full." Well, MACRA began to change that through a notion called risk sharing, which said, we're not going to pay you to do your job poorly. If you can't deliver your services and get people healthier, we're not going to keep paying you to do the wrong thing. So risk sharing said, one way or another, you will participate. If we pay you for services and you need to deliver less services than we might expect because the patient is healthy, then we're with you and you will make more money. But if we pay you for the reasonable level of services, and you don't take care of that patient comes back for a 30-day readmit to the hospital, you got to cover that. That's yours. You eat it. That's the notion of risk sharing. And that carries through and is evolved, and there are a lot of models in there we're not going to go into in this class, but that notion of that pivot point occurring in 2015 is what I want you to keep in mind. Now, there was also something else that came out of this, and this is really out of high tech, and then was really incorporated and given significance in MACRA, and that's called meaningful use, and it means meaningful use of technology. And so it had 3 stages. The first stage was requiring that hospitals or healthcare providers who wanted to receive the greatest payment. So again, MACRA not only had risk sharing, it had some requirements that said you had to adopt health information technology. And MACRA also then said, if you can demonstrate that you have met certain requirements using certified technology, then you will be paid more than if you are using paper or using technologies that don't meet the standards that we need, or if the way you're using the technology, even if the technology is certified, if you're not using it in a way that meets standards, you will be harmed financially. So high tech, through meaningful use, set the standards. MACRA, through shifting financial models, began to say, this is why you want to do this. This is your incentive for following those requirements. And so the first stage was between 2011 and 2012. It involved what was called data capture and data sharing. And we're going to talk about what we mean by sharing in particular in a moment. By 2014, we had what were called advanced processes and health information exchange as a requirement. And by stage 3, 2016, it began to shift to improved outcomes focus. So you see a logical shift here during this period that was incrementally following exactly what we would expect between high tech in 2009 and MACRA in 2016. Now, when we talked about that word sharing in stage 1, the way that was accomplished, remember health information exchange, let's go back just for a second. Sharing in stage 1 was the operative idea. Health information exchange in stage 2 was the key idea. Sharing meant producing a piece of paper at the end of an encounter that you could hand to the client, the patient, and say, here you go, here's your health information. When you go see your other doctor, you can give him this. That was it. I find that mind-boggling, but that was it. And that was called, the form of that document was called a continuity of care document, or CCD. And it had to include these elements. You can see them all. They're pretty good shotgun, but there was no stipulation for what kind of depth they needed to be there. It was more of a free form, extract from your electronic health record these fields in some form and print them off and give them to the patient. Don't think about it again. If you did that, you had accomplished the intent of stage 1 meaningful use. I will admit here too, when I saw this and I saw what I consider to be such a shallow effort to communicate information, because it could be anything. You could have almost nothing, or you could have a very robust statement. It didn't mean it was necessarily not inclusive, but it certainly left plenty of room for that. So for stage 1, as long as you could give your patient a piece of paper that had these headings on it and a bunch of words after that, you'd met the test. That was followed by something called the Consolidated Clinical Document Architecture, CCDA. And so as we're talking about consumer health informatics, understanding where we came from, where the nature of what we got out of the healthcare system was that CCD, then they overlaid it with this clinical document architecture, which didn't get at the content, but it began to stipulate standards. We talk about semantic standards, semantical, they call it. I always want to say semantic. Semantical standards, which are the content, the substance, the meaning of the words being used consistently, and semantic or semantical standards, which mean how do you organize that data file? They're the standards we as technologists like to think about. What defines the beginning of a field? How long is the field? Other characteristics of these various fields. And so they said it needed to be specifically machine readable versions of the CCD. So they didn't change the CCD in terms of its content or its intent. They just said, now you got to make it so that instead of handing them a piece of paper, you can transmit that, or you have the ability to, if you had the ability to transmit it, it would be in a form that another electronic health record system could suck it in and capture and flag and use that information. A lot of assumptions in that short thread. The CCDA simply stipulates the standards around how you have to frame that, and design that, not the full workflow of health information exchange or interoperability between EHRs. It did not require specific content. It has been adopted as the industry standard for creating patient care summary documents. And therefore it shapes really many exchanges. But as we see with the Cures Act, this is just one piece of it. Patient care summary documents is the focus. But it's gone on beyond the CCD to move with the CCDA to move towards images and a wider range. It specifies as a requirement for EHR for vendors pursuing ONC certification. So if you are a provider and you want to get paid the most, that extra bump on your rates, you need to say, I am using ONC certified technologies from vendors who have achieved that ONC certification. And the way I am using that technology meets the requirements, so both the technology and my use of it earn me the points to get the bonus payments that I'm trying to get to, the incentive. So follow the money. Well, under MACRA, we had various forms of risk-sharing models and scoring models about technology adoption. So one that was begun with MACRA and really continues today, although it evolves, is called the merit-based incentive payment system. And I want to linger on that for just a second to talk about how these standards have changed. In the first iterations, if a requirement was that your patients use your patient portal, a form of consumer health informatics, arguably, then you had to have 10% of your patients do that. As long as 10% of your patients do it, you got the full points for that item, and it contributed to your receiving pay bonuses. Excuse me. If, however, you did not get to 10%, then you got 0 points for that line item in the calculation of your score for bonus money. Much more recently, and I'll say I believe with the next topic we'll talk about in the next lesson, the Cures Act, that model shifted. And what I want you to focus on here is not what the model was, but the shift in the way these things work from binary. You either have 10% of your people using this, or you don't have 10%. And so if you have 90% using it, there is no financial incentive different than 10 or 11%. If you have 9% using it, it doesn't matter. If you have 1%, nobody using it, you still have no credit. So it was a binary yes or no system. By more recently, that standard would be to say, we'll measure everybody, every organization, and say what percentage of everybody's patients, of your patients as a part of that population, what percentage of your patients have used the patient portal in the last 30 days, in the last 90 days, last quarter. And then we're going to stratify that, the top 25%, second 25%, third 25%, fourth 25%. So if you're in and this was true of a number of items, I'm using the patient portal as one example that shows how the requirements have evolved and how they influence behavior. So if you find that the top 25% is reached at, say, 90% use, if 25% of all providers have 90% or more of their patients using their patient portal, then they're the ones that get the high points. A smaller bump for those in the next 25%, which might be 75 to 90%. nothing for those below, and perhaps a penalty for those in the last 25%. So you see how it shifted from binary. Do you have 11%, 10%, or not? To a sliding scale, which has the effect of what? Of putting people in competition with each other. Suddenly, Indiana Health is competing with Mayo Clinic, but also competing with some small hospital in Marquette, Michigan, in the shore of Lake Superior. Everyone is looking at where is that percentage, and it really changes the dynamic, not only within an organization, but between organizations. And whether it's the merit-based system or other alternative payment models, we'll talk more about these as we go, but the idea is they all had that same characteristic of saying you must work towards improving health outcomes, and you must work towards adopting health information technology. Meaningful use now has evolved to become interoperability, the interoperability program. So when you see us talking about interoperability program or meaningful use, they're really the same thing, albeit that the standards evolve, and that progression I talked about of how they've scored them has evolved. Know that when we talk about interoperability, or you read about interoperability program, it's the same thing. And we've talked about the patient portal, so I got ahead of myself a little bit. Now, as for me, I wrote this on October 14th, 2019, when there was a new mandate that we would have another form of consumer health informatics, telehealth. Now, this was pre-COVID. So telehealth was out there. It made too much sense, but there were not incentives. And so the government tried to promote some incentives towards the use of telehealth solutions. Online, speak to your clinician through a computer in lieu of having to go to the facility. And I wrote this. I confess this isn't the first time I've thought we were on the cusp of such an important transformation. I was wrong with the Affordable Care Act. I was wrong with the Excellence in Mental Health Act, MACRA, and it seems to me a dozen other initiatives that sounded like they were compelling incentives for telehealth or for consumer health informatics innovation. With the benefit of 2020 hindsight, it is easy to see that whatever incentive may have been intended, the larger history of pointless and ever-changing regulations and requirements, combined with a yo-yo-like revenue strategy, has led providers to do the least they could do to meet new requirements, unless it was absolutely certain that the guidance was permanent, clear, and of significant value. And frankly, that was a reasonable strategy in a tough market. So that's my summary of what really happened between 2000 and 2016. It was a time when the government tried to move us in the right direction. We did some smart things. We set up the Office of the National Coordinator. We set up the high tech with a lot of standards, and we began to move payment models towards health-oriented outcomes. And that's the end of that period. Next up, we're going to look at lesson 3, and for the next 3, 4, and 5, we'll all focus on aspects of the Cures Act. See you shortly.